Sorry. Thank you very much for the introduction, and thank you, Ria, for inviting me to give this presentation today. So the teaching session is about pediatric inflammatory bowel disease. That is, of course, my very favorite topic in pediatric gastroenterology. I'm really happy that we'll be talking about this today. I believe not all of you will have worked in a subspecialist pediatric gastroenterology unit so far, but I'm sure, I have no doubts, most of you will have come across children affected by inflammatory bowel disease, or children where you suspect there could be a diagnosis of inflammatory bowel disease. And this is really due to the fact that we are diagnosing this condition more and more often. So while it was, used to be considered a rare disease, it's definitely no longer a rare condition these days. So irrespective of whether you're based in a DGH or in a tertiary level, where you're based in gastro or not, you will sooner or later manage one or more patients with inflammatory bowel disease in the pediatric age. So the aim of this presentation is really to give you some tools that will allow you to be able to work together with a pediatric gastroenterologist to know, of course, what the definition and what the main management of the condition is, how you diagnose it, and what the main treatments are that the pediatric gastroenterology will put in place depending on the characteristics of the inflammatory bowel disease. So hopefully with this presentation, you'll be able to speak with the child, speak with the family, and collaborate with the pediatric gastroenterologist a bit better than before the presentation. I'm really happy to share the slides as well afterwards. So let's go in order, and let's start from the definition of inflammatory bowel disease. And I don't think this is a trivial or boring slide, in that we all remember from medical school the difference between Crohn's disease and ulcerative colitis. And you see in these photos here on the top photo, it's clearly a picture of ulcerative colitis, and an endoscopic picture showing erythema, granularity, fibrin adhesion, continuous ulceration of the colon. Whereas if you look at the bottom photo, this is very different, and this is clearly Crohn's disease. It's skip lesion, cobblestone appearance, and very sort of serpiginous deep ulceration. And this, is the extreme presentation of ulcerative colitis versus Crohn's disease. And I still think it's very important that we keep it very clear in our head, and that we do remind ourselves what are the main difference between the two conditions. And so you remember that ulcerative colitis is mainly restricted to the mucosa and submucosa of the large bowels of the colon. It's a colonic disease, whereas Crohn's can affect any tract of the gastrointestinal system. And Crohn's normally is deep, involving the intestinal wall with transmural inflammation. However, while it is important to have this simplistic difference in our heads, it's also very relevant that we remind ourselves that things have been changing and are changing, and most of the time, a child with Crohn's disease might be very different from another child with Crohn's disease. Sometimes you can't even make a definitive call as to whether the child has Crohn's disease or ulcerative colitis. So this is definitely inflammatory bowel disease, but the endoscopic and histological pattern will not tell you 100% whether you can call it Crohn's or ulcerative colitis. So you will need to rely on your experience, you need to rely on the clinical presentation, you need to put all these elements together, and you probably make a call to say this is an IBD-U, unclassified, and that is Crohn's-like or ulcerative colitis-like, depending on the features you're observing. And so IBD-U does not mean that you're not sure whether this is inflammatory bowel disease. You definitely know it is inflammatory bowel disease, but you can't really define it as Crohn's or ulcerative colitis. And why is that? And that is probably because IBD is more of a spectrum rather than just, extreme Crohn's versus extreme ulcerative colitis. You may come across clear-cut Crohn's and UCs, but in many cases, each child, they have their own IBD, basically. So it's very important to always define where the IBD is, so the disease location, endoscopically, radiologically, and it's always very important to put all this information into the right context, which is the history, the clinical presentation, and we'll go through all this together. So if we go back to the first line of this slide, this is why the definition is IBD covers a heterogeneous group of chronic disorders, plural, of the digestive tract, causing relapsing, remitting inflammation of the mucosa. It's heterogeneous. It can be, very varying, and it is important we remind us that as we go through the teaching today and when we see our children. So because it is complex, because it's not always crystal clear whether it's Crohn's or colitis, for both conditions, Crohn's and UC, we do have classifications, and classifications are really a way to remind us what are the important items that we need to describe, we need to know when we're discussing a child, when we're seeing a child, when we're making decisions around a child's management. So that historically, two important classifications have been the Montreal classification of Crohn's and of ulcerative colitis. That was established in 2006 by a panel of experts, worldwide experts in IBD, both adult and pediatrics. As you can see in this table, the important parameters are age at diagnosis. If you stick to the Montreal classification column, you see that they basically make a difference between pediatric age at diagnosis of IBD, young adult age up to 40, and sort of older age in the adult spectrum above 40. It's very important to know the location. So L1 in the Montreal classification will be a Crohn's disease located at the terminal ileum or the small bowel, not just the terminal ileum, any small bowel. But it can also be ileocecal Crohn's, so very limited Crohn's disease confined between the terminal ileum and cecum will be L1. So L1 in your head should be small bowel, maximum cecum. L2 is colonic Crohn's and colon only. L3 is ileocolonic, so both involvement of the small bowel and the large bowel. And L4 is when the upper gastrointestinal tract is involved. So you see there's gastropathy, there's duodenopathy, and the histology will describe features of Crohn's disease in the upper GI tract. And another important element in the Montreal classification is the behavior. So if we look at the disease course, IBD is inflammatory and may just be an inflammatory condition that affects the intestinal lumen, the mucosa, the submucosa. So B1 is non-stricturing, non-fistulating or penetrating. B2 is when the disease course actually evolves in a way where the patient develops a stricture somewhere between the small bowel and the large bowel. B3 is when you diagnose the presence of fistulae, either within the bowels or perianally. And P is when there is perianal disease associated with your Crohn's disease diagnosis. As you can see, the Montreal classification did not take into consideration growth and whether the child or the young person is growing or has achieved an appropriate growth target. But these aspects were kind of amended by the Paris classification that was introduced in 2010, and it's kind of more looking into the pediatric part of our patients. So there's a age subcategory differentiating patients between 0 and 10 years of age and patients between 10 and 17 years of age at diagnosis. This is just really to tell you that the earlier you diagnose IBD in a child, in a patient, the more intense and challenging the disease course may be. It's not as simple as this, but it is always very important to know at which stage in the patient's life IBD was diagnosed, because an earlier onset will basically guide you to monitor specific aspects in a way that's probably more intense and more careful than you would do for a young adult or for an older adult with same kind of disease label. Location-wise, the Paris classification is very similar to the Montreal. The only difference they introduced was the upper GI tract is divided as L4A when the upper GI involvement is proximal to the ligament of Treis, and L4B when the upper GI and small bowel involvement is distal to the ligament of Treitz. And behavior-wise, they introduced a B2, B3, so you will have patients with both a stricturing and a fistulating or penetrating phenotype of their small bowel Crohn's disease. And most importantly, the Paris classification introduced the growth element. So G0 means there is no evidence of growth deficiency or delayed growth, but G1 actually describes those patients where you can actually document that there has been a growth delay. If we look at ulcerative colitis, it's a bit easier, a bit less complex. So both the Montreal and the Paris classification use a letter E for extension to define sort of different extent of UC. E1 is UC proctitis, so it's confined to the rectum only. E2 is when ulcerative colitis involves the left colon after the splenic flexure. E3 is when it goes proximally to reach the hepatic flexure or between the splenic and the hepatic. And E4 is UC pancolitis involving the whole colon. And also, very importantly, both the Montreal and the Paris classifications for ulcerative colitis, they do take into account a parameter that is related to whether the patient ever had an episode of severe colitis. So having an episode of UC described as severe disease activity is very important because it may affect the disease severity throughout the whole course of ulcerative colitis. So if you have a child, for example, diagnosed with UC, and at any stage around diagnosis or after diagnosis, the child is admitted with what you would describe as acute severe colitis with an activity index that's very high, describing a severe colitis where you need to really go for IV steroids and quite intense treatment management, you will need to take this into account when you classify that ulcerative colitis, because this child is likely to have a more severe disease course in the longer term, and you will have a lower threshold to reinvestigate, to keep an eye on this child, to monitor him more intensively, and to consider more potent therapeutic management for a child or a young patient who has had acute severe colitis. And I think similarly in adult patients, this is quite a relevant factor. And I must mention an amendment or a sort of complementary addendum to these classifications. This is called the Porto classification. This is quite a relevant publication that was made available in 2014. And it's a classification made by a panel of experts in pediatric inflammatory bowel disease. It's the Porto IBD Working Group of ESPGHAN, that is a European Society of Pediatric Gastroenterology, Hepatology and Nutrition. These experts felt there was a need to add to the previous classifications we just went through, in that in those years, we started collecting more and more data from patients who presented with ulcerative colitis, and clearly that was ulcerative colitis, both endoscopically and histologically in the pattern you would observe. However, these patients were having, for example, rectal sparing. So the rectum would look completely normal, but then from the sigmoid descending colon proximally to the cecum or to any extent, there was a tract of continuous inflammation entirely consistent with ulcerative colitis. So this is, an example of an atypical EUC. It's definitely ulcerative colitis, but it's atypical because the rectum is spared. Another example is patients where you have proctitis, so the rectum is definitely involved in this case, but then you have a completely normal colon from sigmoid to ascending. And then when you go around with your endoscope and you have a look at the cecum, you will see that there is a cecal patch of inflammation. So it's ulcerative proctitis with a cecal patch. So although it looks like patchy, it's definitely UC, it's consistent with ulcerative colitis, and it's accepted as a variant, as an atypical form of UC. Last but not least, from medical school, you remember that UC only involves the colon, is a colonic disease. You some of you will know already that sometimes the terminal ileum might be indirectly affected by something called backwash ileitis. Is when the colon is quite severely inflamed, so you will have some indirect involvement of the terminal ileum, and you will find inflammation there. But in the recent years, more and more often, we are seeing some upper GI involvement in patients with clear ulcerative colitis. So you will see gastropathy is definitely the most frequent, sometimes some changes in the duodenum as well. They may accompany an otherwise completely clear diagnosis of ulcerative colitis when you then do the colonoscopy. So if you find disease of the stomach, you may think, oh, it's upper GI, so it must be Crohn's disease, because by definition, ulcerative colitis is not associated with any other extent except for the large bowels. But actually, it is possible to have gastropathy and ulcerative colitis, and that's described as atypical UC, one of the possible presentations. So I hope, going through the main classifications is kind of helpful to brush up our memory and to really remind us all that you've got Crohn's, you've got ulcerative colitis, but there are many types of Crohn's, many types of ulcerative colitis, and sometimes you will have an IBD unclassified, where you will describe it, if possible, as Crohn's-like or ulcerative colitis-like, and you will try to manage the patient accordingly. We mentioned at the very beginning that IBD is becoming more and more frequent, and we are seeing it very frequently in many different age categories, but definitely adolescents, young adults being diagnosed with IBD more and more. So compared to years ago, the situation has changed. Classically, when you think about IBD epidemiology, you will read a lot about the north-south gradient. So countries historically with the highest incidence of IBD are definitely Canada, United States, North Europe, Scandinavia, for example. But interestingly, what we've been observing is that countries where IBD was rare, definitely little known and very rarely seen and managed, where there has been a westernization and industrialization and a lifestyle that definitely changed towards a more westernized style. These countries have seen a major growth in their numbers of new diagnoses of inflammatory bowel disease. So we're talking about, for example, Far East, some areas of Asia, and this, has been changing gradually and quite increasingly. And there are very interesting studies as well that are migration studies. So if you look at populations that individuals that used to live in areas where IBD was not frequent, when they move to a country where IBD is much more frequent, let's say Canada, United States, North Europe, for example, you will see that the following generation will have the same epidemiology incidence of inflammatory bowel disease as the country where they move to. This is very interesting because it makes you think the environment must play a role. There must be something in the environment that kind of triggers the development of IBD, because people coming from areas that are unaffected, so genetically they don't seem to be predisposed, traveling to countries where IBD is diagnosed all the time, will then develop a risk of developing it, which is absolutely the same as the local population. So the problem with epidemiology is that to have strong epidemiological data, you need to run large studies, studies that normally require time, and they need to be very well structured. So the data we've got at the moment is sometimes all the data. If we look at worldwide population data or large area data, for example, if you want to know about North America, the whole of Europe, even looking at UK data, what I'm showing here is data from reporting in the NICE guidelines in 2013, but then we'll need to collect the data that's being analyzed at present to update this data with newer numbers and more recent numbers reflecting where the situation is at the moment. So there are excellent studies about epidemiology data in IBD, both pediatric and adult, for example, from Scotland, from Canada, definitely, and some nationwide studies. It's more difficult to put all these numbers and data together to look at larger areas in the world. But I think, if you look at this older data from probably 10 years ago, North America, incidence of Crohn's was around 20, incidence of UC was also around 19, 20. In Europe at that time, Crohn's was definitely less incident, but UC was kind of the same. Asia and Middle East were definitely showing lower incident numbers than Europe and North America, but this has changed enormously in only 10 years or so. This is where the UK was around 2013. This was published in 2013, so probably it reflects 2010, 2011. But you see how this number, so an incidence IBD of 5.2, of Crohn's of 3.1, of ulcerative colitis of 1.4, they've at least doubled, if not more than double these days. So we'll keep an eye on the epidemiological data and studies to make sure we are all updated as the data becomes available. So one of the main messages around IBD is that no one has really identified a single specific cause for the condition. Is complex and is thought to be multifactorial. We know that there must be, to some extent, some genetic predisposition. We definitely know that environment is playing a big role and seems to be triggering inflammatory bowel disease. We know that there's a big role in the microbiota and of course the luminal microbial antigens and adjuvants, and we know the immune system is no doubt involved. And we all know it's abnormal response of our immune system that generates chronic inflammation in the gut. So these four elements all together are understood to be key players. But I always tell my students and younger colleagues, if there's anyone who could ever be able to find a single cause of inflammatory bowel disease, I'm sure that person will deserve a Nobel Prize, because we haven't got that at the moment. So we are understanding it more and more. We are discovering pathways, we are targeting biological pathways, but we don't know what the primary trigger or cause really is. And we kind of have all these factors interplaying, and they're all together in the way we understand inflammatory bowel disease. Looking at genetics, we know from a number of studies that there's a series of variants or mutations that have been identified, and they have been linked up with predisposition for Crohn's disease, ulcerative colitis, or IBD in general. However, the tricky element of this is that if you look at the total number of patients, these genetic variants or mutations will only explain less than 1/3 of your patients. So 2/3 of them, you probably won't be able to find any genetic predisposing mutations or variant that would explain why they develop inflammatory bowel disease. Of the genes we have identified, of those we know do play a role in IBD, the majority play a role in biological functions that include immunomodulation, mucosal barrier integrity, and microbial homeostasis. There's then a separate chapter that you see in the bottom part of the slide, and this separate chapter is all pediatric, and it's about very young children developing inflammatory bowel disease. So you do an endoscopy and you really see ulceration, you really see a pattern that's IBD, like phenotypically looks like IBD. And we call these children early onset when they're diagnosed with inflammatory bowel disease below 5 or 6 years of age, and very early onset when we find these phenotypic presentations of IBD below 2 years of age. However, it's very important to run more tests and to really assess these children clinically in a structured way. in that it's likely they will have a monogenic course or polygenic course of their IBD. And it's likely their condition is not just IBD. You see IBD in the gut, but they're likely to have an immune deficiency, a congenital or genetic immune deficiency that associates with intestinal chronic inflammation. So there's a number of genes that have been discovered and identified. Some of these conditions you probably will have heard of, for example, a deficiency in the IL-10 receptor. IL-10 is an anti-inflammatory pathway. So if it is deficient, there will be like inflammation, chronic inflammation in the bowels. And some of these forms really associate with very nasty perianal disease and a very difficult to treat paediatric Crohn's that will require escalation, will probably not respond to standard treatments and may only benefit from a bone marrow transplant. And there are other monogenic or genetically based forms of early onset IBD involving different genes like IL-2 receptor, for example, FOXP3. So these are not standard IBD, not the classical chronic inflammation of the bowels only, but if you identify these mutations by running a panel or a screening, you will know this child is affected by an immune deficiency that also includes chronic inflammatory phenotype of the bowels. So it's a separate chapter. And so we've talked about some genetic predisposition, yes or no. We've talked about environment. We've talked about microbiota, which is probably, lying in between the environment and our gut and our cells and our genes. There's lots of discussion these days and lots of studies actually ongoing about epigenetics. What is epigenetics? Epigenetics really studies the mechanism that determine changes to our cell phenotype, but they do not imply any changes in their genetic sequence. So your genetic code is exactly the same, but what changes is the way genes are switched on or off, whether they're upregulated or downregulated, and how the interplay of different genes potentially involved can really change the cellular phenotype and may underlie diseases and conditions. So because of this lack of clarity between how much the environment is playing a role in causing inflammatory bowel disease and how much it's written in our genes, people scientists have wondered whether epigenetics may be the missing link. So we're talking about, DNA methylation, for example, histone acetylation, processes that are just above the DNA. They don't affect or alter the DNA, but they really regulate the way genes are activated or inactivated. Could a dysregulation of epigenetics mechanism be the underlying mechanism of inflammatory bowel disease? There are interesting studies all around that nicely describe some correlation, but of course we don't know yet about a sort of cause-effect correlation. And so going back to the more clinical elements that we would like to share today, what do we do? How do we manage these patients? What can we do in the setting where we are working, be it A&E, DGH, tertiary level, to then contact the gastroenterologist and work together and make sure we do all we can for this child for, the most appropriate management of a suspected IBD or a known IBD we are reassessing. So, of course, it's always very important to assess the child clinically, take history and examine the child as thoroughly as possible. It's equally important to send some biochemical investigations. Both blood tests and stool tests will help us a lot. Although it's not just a battery that you send, you always need to think, why am I sending this test and what do I expect to know from this specific blood test or from this stool test? You've got some radiological investigations that will help you a lot to assess the small bowel and the large bowel. And of course, the gold standard will be an endoscopy, upper and lower endoscopy and biopsies. But there are situations where endoscopy on its own will probably not help you 100%. So you'll need to definitely do the endoscopy or have it done by the gastroenterologist, but you will need to put it together with the radiological investigations and your history and clinical examination and blood and stool tests. And I can't really tell you how important it is for us when we are contacted about a query new inflammatory bowel disease to hopefully have all this information, and it's not just the endoscopy on its own, it's never that. So what do you do when you take your history? There are many things to ask. Of course, you'll ask about traveling. You'll think about, could this be an infective, diarrhea, for example, colitis. It's very important to ask about the chronicity of the presentation. Normally, we suspect this could be inflammatory bowel disease if the diarrhea has lasted more than 6 weeks. If the history is 2 weeks, 3 weeks, well, you never know, it might still be IBD, absolutely, but then you will need to ask a bit more about possible infective causes. And most importantly, always remember to send stool cultures, stool virology and Clostridium difficile. We are quite reluctant to do, a general anesthetic and an endoscopy in a child with a 2 weeks history, even when we think this could be inflammatory bowel disease, and we'll probably do the endoscopy in that case. But just a short history is always a bit like, it could be an infection. We don't know. So it's very important to make sure we check the stool test, the stool samples for infections. Then, of course, there's a number of signs and symptoms that normally make us think of Crohn's disease. For example, a child with a chronic history, weight loss, fatigue, tiredness, anorexia, poor appetite, and temperature. These are all signs and symptoms that make you think about something systemic. It's not just a bowel condition, it's having repercussion on the whole system, on the whole body. So when there's weight loss and systemic symptoms, we normally think this could be Crohn's disease. However, an ulcerative colitis could be bad enough and severe enough to also cause some weight loss. So you can never be sure 100%, but this is normally what we consider systemic symptoms. Of course, it's always very important to ask questions about perianal disease. Have they noticed discharge? Have they felt perianal pain? Is it difficult for them to sit down? And when you examine the child, always go for a perianal examination as well, because more than 10% of patients with Crohn's will have perianal associated perianal disease. If a child presents with different symptoms that are mostly urgency, tenesmus, rectal bleeding, this is what we normally call colitic symptoms. This makes us think about a left-sided disease that could be ulcerative colitis. You never know, it could be a Crohn's colitis, but because it's colitis, although being Crohn's, you still see blood, urgency, tenesmus, anemia. But roughly, this is the idea we have when we take history, examine a child, and they're presenting with either systemic symptoms or colitic symptoms. And then it's really important to ask about elements that are outside of the gut. So extraintestinal manifestation, you all know that both Crohn's and colitis can present with involvement of other organs, and this is because the inflammation goes more systemic and ends up affecting other systems. So musculoskeletal extraintestinal manifestations include sacroiliitis, ankylosing spondylitis, peripheral arthritis. I don't think you need to go into details here, but make sure you ask questions about joint pain. Check if there's any joint swelling and describe as much as you can what you see when you examine the joints. Eyes, always ask about eye symptoms, redness, conjunctivitis. IBD can be associated with episcleritis or uveitis. Always check the skin. Erythema nodosum can be associated with Crohn's. Pyoderma gangrenosum can happen to a child with ulcerative colitis. So always look at the skin and ask if they've seen any skin lesions that are either not explained or they've been treated but they haven't resolved. And I think you only need to see a erythema nodosum or pyoderma gangrenosum once to remember it forever. It's quite something that you will recognize straight away once you've had the experience. And Liver is also very important because IBD can present with associated liver disease. We're talking about sclerosing cholangitis, but not just that. It can be autoimmune hepatitis or overlap. And there's a whole, big chapter here. Sometimes the liver is affected first and then IBD develops later, or vice versa. But if, you're seeing a child for query IBD, make sure you think about liver. And when you send the panel of blood tests that you want to send, always include some liver function tests. And so blood test wise, of course, we have our shortcuts and our, blood sets that we normally send. It's like IBD diagnosis, you send all that. But I think, it really depends on the context. So if you suspect the child could have IBD and you are in a setting like I&E or somewhere where you can't send, all of the blood tests you send for a proper IBD screener diagnosis, if you had to select your blood test, I think this is what we normally need to know when we are on the phone and we are on call and you ask us about, a child with a potential or possible inflammatory bowel disease. We'll definitely ask you about the white cell count that's normally raised. We'll definitely ask you about hemoglobin and hematocrit. They normally are anemic or they can be anemic. Platelet count tends to be raised because, of course, of chronic inflammation. We're normally keen to know about both ESR and CRP. The ESR is important because it's also part of the Pediatric Crohn's Disease Activity Index. And it's nice to have both of them because sometimes one of the two is raised and the other isn't. So it's always helpful to, possibly, if possible, have both numbers. Albumin is really important because IBD really tends to be associated with lower albumin. And the fact that they are low in albumin is not just because of the chronic diarrhea. You might think, well, maybe they're leaking proteins, losing proteins, or they're not absorbing proteins from the bowels. That's absolutely true when IBD is severe. But the other mechanism is the liver is so busy producing all the inflammatory cytokines and pro-inflammatory mediators that it basically produces as albumin. So it's also, a synthesis kind of element that will lower down your albumin level in these patients. And of course, we said, make sure you run liver function tests. And this is really what we would probably ask you on the phone. Never forget to check, of course, for nutrition, hydration. So we will want to make sure that sodium and potassium are in the right place. Creatinine and urea and renal function tests are also checked. That all of that should be done. But IBD-wise, the top 4 lines here are really normally the blood tests that we really want to know where we are asked to offer a consultation. And looking at the stool tests, so all of you will have heard of fecal calprotectin, which is an inflammatory marker that's more specific to the gastrointestinal tract. And don't get me wrong, it's absolutely helpful and important. It's nice to have a baseline fecal calprotectin, and it's definitely helpful to use it to monitor the disease course of a known inflammatory bowel disease. When you want to know about response to treatment, the fecal calprotectin will be more accurate than an ESR or CRP to tell you if the patient is responding. However, we should never base our discussions on a fecal calprotectin only. For example, a 3-year-old child who looks absolutely well hydrated, well perfused, and he has a sky-high fecal calprotectin of 2,500, for example, I probably won't think about IBD if it's looking well, but I'll probably think about maybe it's got a polyp, maybe the polyp is bleeding, and the presence of blood will raise the fecal calpro because fecal calpro is a neutrophil-based marker. So, for wherever there is blood, it will always be raised. And you could get blood in the stools because of a polyp, because of severe constipation with straining and mucosal tear. So any cause of blood will raise your fecal calprotectin. So always put the fecal calpro in the right context. If the context is suggestive or possibly suggestive of inflammatory bowel disease, we normally expect it to be at least 250 or 300 to feel like, oh, this could definitely be IBD. If it is just between 50 and 100, we are probably a bit unimpressed, and we will definitely need even more so to put in the right context. So use it, but together with everything we've said so far, not in isolation. And always remember to send stool cultures, particularly if the history is shorter than 6 weeks. We Sometimes you may find CD for Campylobacter colitis, and you want to treat that before you consider a diagnosis of inflammatory bowel disease. Imaging helps us a lot. So ultrasound is important. It tells you about the bowel's wall. If it is thickened, if the Doppler is a high signal, it's suggestive of inflammatory bowel disease. With ultrasound, you can also assess the presence of abscesses and fistulae. Even more accurately, small bowel MRI and CT can be used. CT, we try to limit or not use it in the pediatric age, but of course it will be used in adults. Small bowel MRI is a great technique that tells you about small bowel and large bowel involvement. Is there any stricturing? Is there any fistulae? Is there any bowel wall thickening? And signal from perfusion, from vascularization. So putting all this together, you'll be able to know about the disease extent. And always remember, imaging is not an alternative to endoscopy. They are complementary. So endoscopy tells you about the lumen, so about the mucosa, and you will know where the luminal disease is. But MRI will tell you if there are any strictures and will tell you about transmural element of your Crohn's disease, for example. We normally run them both, and then we combine the results, and we know what the IBD looks endoscopically and on the MRI, and merging the two techniques will really tell you the disease location that we discussed when we went through the classification of IBD. And then, of course, you now know where it is, you now know what to ask and how to assess the child. You always want to discuss with someone how active you think this IBD is. So if you're assessing a child with Crohn's disease, you will use the Paediatric Crohn's Disease Activity Index. So that is basically a series of questions that cover abdominal pain, how intense it is, stools, characteristics, how often they're going, general well-being, how tired is the patient, how limited they are in doing their general usual activities, any non-voluntary weight loss of importance, growth-wise, have they been slow in reaching their high target and crossing their centiles appropriately in pediatric age for sure. Abdomen, how does the abdomen examine? Perirectal disease, like I said, always check for perianal disease and describe it if it's there, and that will contribute to the Crohn's disease activity index score. Presence of extraintestinal manifestations, we've discussed about that briefly. And then you need to know the hematocrit, the ESR, and the albumin. There is an abbreviated version where you don't need the blood test results. You can just, calculate the score based on clinical symptoms and signs only. But this PCDI, when you put all these numbers together, will give you a score of 40 or above if the disease is severe, 30 to 40 if it is moderate, and 10 to 30 if it is mild. Below 10 will be remission. And similarly, for ulcerative colitis, you ask them about abdominal pain, rectal bleeding, stool consistency, number of bowel openings over 24 hours. Are they opening the bowels in the middle of the night and waking up for that? That's nocturnal symptoms. And the general activity level. And the sum of all these scores will give you the final result. If it is 65 or above, we're talking about acute severe colitis. That's a severe presentation we discussed about when we mentioned the Montreal and Paris classification of ulcerative colitis at the very beginning. So it's very important to know how severe it is. If it is severe, it's very likely the child will need to be admitted for quite, more intensive treatments. So last part of the presentation is which treatments have we got for our children with inflammatory bowel disease? And this pyramid hopefully summarizes it all for you, but it's not as easy as it looks. So the first thing is, treatment-wise, you give treatment because you want to induce remission. So at the very beginning, you want to really tackle the inflammation and make it disappear. But then in the longer run, you want to maintain remission. So you will need to probably find some different remedies or strategies to make sure that the inflammatory bowel disease doesn't bounce back to be active again. You also want to give drugs that are tolerated because you want to limit drug toxicity. So looking at the pyramid, you can, feel like I've got time to start from the base of the pyramid and, slowly or gradually or less slowly, try to climb it and do what the patients need. Sometimes you need to go top down and, if a child presents with a very active panenteric and perianal Crohn's disease, for example, there is no way you can climb the pyramid from base to top. You will need to go top down. So you will definitely consider a biologic treatment straight away if they've got perianal disease and panenteric Crohn's and are very unwell when they present. Similarly, if you've got UC and it's acute severe colitis, you can't just give, 5-ASA, which is mesalazine. You'll need to definitely consider steroids plus or minus biologics, depending on the response to the steroids, and you'll need to keep the child in hospital. So in Europe and in the UK, we tend to go step up as much as we can. In the United States, North America, they will probably go top down a bit more often than we do. And sometimes it's not right or wrong. It's just making sure that you're monitoring how the child responds and then you act accordingly. So when you have a diagnosis of Crohn's and you don't need to go top down, the first thing you consider in the pediatric age is to keep the child the course of exclusive enteral nutrition. Probably most of you will have seen children being given this special milk called Modulin, which is an anti-inflammatory formula enriched in TGF-beta, and is a polymeric formula, and it's got properties that basically allow the ulceration and the inflammation to disappear. And it's quite effective. It works in many cases, and it's as effective as the steroids. That would be your other option if the child was not really tolerating exclusive enteral nutrition because they don't like it, because they vomit it, because they don't think, sometimes adolescents just feel I can't do it for 6 weeks, because when you give exclusive enteral nutrition for Crohn's disease, they need to stay on that only for 6 weeks. So they're not allowed to eat or drink any other food because the milk will cover all of their requirements. And that's the only way at the moment that you have to really treat the Crohn's disease effectively. There are studies about, can we give a bit less? Can we use specific diets alongside exclusive enteral nutrition to really treat the Crohn's? There are promising studies, promising results, but at the moment we still need to offer exclusive enteral nutrition in the standard clinical setting. If you're then part of a clinical trial around new diets and IBD, it's a different context, and you can definitely try that, but that's not what's recommended by the guidelines so far. And for ulcerative colitis, 5-ASA, this is mesalazine, is your first medicine. And if the ulcerative colitis is mild or moderate, they may actually just respond to 5-ASA, to mesalazine. You may just want to continue it longer term because you may never need to step up and give them steroids and go to the second step of the pyramid here. 5-ASA is definitely a good drug for ulcerative colitis, particularly when it's mild or moderate. And we still continue it alongside other treatments when ulcerative colitis is severe, because 5-ASA is very important to protect patients with ulcerative colitis from the development of colon cancer in the future. So it's a drug, we use it basically all the time in ulcerative colitis, unless they develop side effects to that, of course. So if you climb the pyramid a bit further, you have the immunomodulators, azathioprine, 6-mercaptopurine, or methotrexate. This is what you use when you've tried induction and you feel the patient needs some maintenance. Maintenance with 5-ASA is not enough in your ulcerative colitis patient. You will consider giving azathioprine or 6-mercaptopurine. Or your Crohn's disease patient, you do exclusive nutrition or you do steroids, but you feel that Crohn's needs maintenance because it's either relapsing again or it was quite moderate at presentation. You're not comfortable to just leave them with no treatments. And then you'll consider immunomodulators for Crohn's, either azathioprine, 6-mercaptopurine, or methotrexate. And then when you really are dealing with a patient who's not responding, who's relapsing, and you've attempted these first steps with no complete response, or only short-lasting response, you'll need to consider escalating to biologics. Sometimes, like I said, you use biologics straight away after diagnosis if you need to go top down because of perianal, because of very extensive, very bad disease. So in summary, for induction or remission for Crohn's disease, you've got exclusive enteral nutrition. That's always our favorite options in pediatrics because it will give them less side effects compared to the steroids. The efficacy is good and it's very comparable to the steroids. And so only if you're desperate and cannot tolerate it, you will consider the steroids. There's limited efficacy of 5-ASA reported in the literature for patients with Crohn's disease. However, sometimes when you've got Crohn's colitis, you may consider adding 5-ASA if the patient is, finds this benefit, they bleed a bit less, they've got less tummy pain, but definitely not as a treatment on its own for Crohn's disease. For ulcerative colitis, you try the 5-ASA when it's a mild or moderate, and you consider going up to the steroids if it's moderate severe or there is no initial response to the 5-ASA. This is induction of remission. For maintenance, you have your thiopurines, azathioprine, this is the dose 1.5 to 2.5 milligrams kilo a day, or 6-mercaptopurine, that is this active metabolite. So if a patient had sort of idiosyncratic side effects to azathioprine, you may consider trying giving 6-mercaptopurine. The dose is half, more or less, of the dose of azathioprine. And for example, someone who vomits on azathioprine, who has headache on azathioprine, or who develops a rash, you can consider 6-mercaptopurine. So these thiopurines inhibit the B cells and the T cells. This is their mechanism of action. You should also always check TPMT. TPMT is thiopurine methyltransferase, and it's an enzyme that really tells you if the patient can tolerate the drug, because it's the enzyme that processes the drug. And you should check the TPMT at the very beginning when you send your initial blood test, because the endoscopy shows you IBD and you want to complete your initial investigation. And if the TPMT is absent, the patient is deficient, you will not be able to use azathioprine or 6-mercaptopurine. If the TPMT is slightly low, you may want to give the patients like half a dose of the azathioprine or the 6-MP accordingly. And the good thing these days is that you're able to monitor the metabolite level. So after a few weeks of azathioprine or 6-MP in a patient where your TPMT has already told you that you can use those treatments, you can actually check the active compound that's called 6-TG, 6-thioguanine, and you can check another metabolite that's called 6-MNN. This is a metabolite that's toxic to the liver. So you can measure these levels in the blood, and you can see if you need to decrease the dose or to up the dose based on where you are with the active compound that you want to be in the right range, and the toxic compound that you definitely want to be below the threshold. If for any reason your patient develops important side effects to azathioprine, 6-mercaptopurine, for Crohn's disease, you can consider methotrexate as an option. You will know about methotrexate from other diseases and other conditions. You will remember the mechanism of action. It must be given alongside some folate supplements, because of course it will inhibit your production of folic acid. And so you normally give methotrexate once a week. It's given either subcutaneously or oral, depending on what the patient needs and how it's tolerated. And it's normally 15 milligrams per square meter for a maximum of 25. We normally stop at 20 in the pediatric age. So this is a figure just showing you how azathioprine is processed to 6-mercaptopurine. And how 6-mercaptopurine is then processed, metabolized in the active compound and in a toxic compound that you want to make sure are in the right range where you want them to be when you monitor these patients. And this is how your TPMT activity will allow you to decide how much azathioprine you're going to give the patient. So if the enzyme is produced in a normal range, you give 1 to 2 milligrams per kilo of azathioprine. But if there is a slight deficit of that, you go for 1 milligram per kilo. If it's completely absent, you will not use azathioprine or 6-TG, because they will not be able to metabolize it and you will have lots of toxic compound. And then to nearly conclude the talk, we have the biologics. You will have heard of infliximab, which is an engineered monoclonal antibody. Is 80% human, 20% murine. Is given as an IV infusion at time 0, then after 2 weeks and after 6 weeks. And again, we're lucky these days, because as opposed to 10 years ago, or 5 years ago, sometimes we are able to measure its trust level, its concentration in the blood. So we want ideally its concentration to be somewhere between 3 and 7. And according to the recent studies, the PAN study, most importantly, we really want to be as close to 7 as possible. And infliximab is a good biologic because studies show a remission of IBD at 1 year of around 65%. Of course, it can have side effects, and they need to be monitored. It's normally used when children haven't responded to the conventional steps we've just been through, and or if they've got perianal fistulizing disease, we'll go top down with using infliximab at the very start. And then you've got adalimumab. Adalimumab is also an anti-TNF, but it's fully humanized, and its subcut is given every other week. And we have more data for infliximab. We normally tend to start from infliximab, and if the patient develops anti-infliximab antibody, and so the level is low because there's an anti-drug antibody reaction, you may want to switch to adalimumab being fully humanized as a lower chance of developing anti-adalimumab antibody. Of course, these are only two anti-TNF alpha. Research is investigating on so many potential options, but you know very well how research works. You're in phase 1-2 here, you got so much potential, and then when you go closer to phase 3 registration and launch, you only have a few biologics that actually pass the tests. So very interestingly here, it's probably a bit of an old photo, but you've got ustekinumab, and here close to the center you've got vedolizumab. So we are definitely using vedolizumab and ustekinumab off-label at the moment in the pediatric patients. They are used in label in adults. Vedolizumab is an anti-integrin biologic, so it's not an anti-TNF alpha. It will just block the trafficking of your lymphocytes between the vessels and the intestinal mucosa. It takes a while to become active, but normally, at 14 weeks from the start, you're able to see if the patient is going to respond or starts, showing signs of response. And it's a gut-specific biologic, it's very interesting. The ustekinumab instead is an anti-interleukin 12, anti-interleukin 23, so very different mechanism of action, which is also used off-label for pediatric inflammatory bowel disease. And surgery, for Crohn's, we always think we should avoid surgery because Crohn's is relapsing. It can involve any tract of the small and large bowel. So if I resect part of the GI tract, I may have a Crohn's relapse elsewhere. However, if you have a stricture, you will need surgeons to help you resolving the stricture. I mean, you can definitely try biologics, you can try medical treatments of the stricture, but if it is persistently there causing subocclusion, subobstruction, you will end up calling the surgeons for a resection of the stricture. If you got fistulae, particular perianal surgery, you may need fistulotomy or fistulectomy. There are two different approaches of either opening the fistula or resecting the whole area, basically. And then if you've got a very limited Crohn's, like ileocecal Crohn's only, and you can document that nothing else is involved, then you'll be able to do an ileocecal resection, so a very limited surgery, because you're confident that everywhere else your Crohn's is under control and there's no other gut segment involved. For ulcerative colitis, the situation is different because it's the disease of the colon, so the surgery, which is the colectomy, will actually eliminate the disease. However, you're left with a child with no colon. Probably you'll just leave a rectal stamp if you do a subtotal colectomy, and they will have a stoma bag where the terminal ileum is brought to a bag outside. And in the future, they may decide to go for an pouch formation, which is you use a terminal ileum to create a pseudo rectum, and a pouch anal anastomosis to try and reconnect the bowels. But although if you do surgery in UC, you definitely eliminate the disease, so the implication for the child's quality of life can be quite, major. So it's, of course, a decision that needs to be made very, very carefully. I think this brings me to the very end. I just wanted to say there are some recent guidelines on managing Crohn's disease medically and surgically in the pediatric age. These are joint ECO-ESCAN guidelines. Now, so hopefully this presentation that was quite basic will give you all the tools to be able to read these guidelines that actually are more subspecialized. So do consider going through the guidelines. ECHO, the European Crohn's and Colitis Organization, also offers quite interesting e-courses. So if you want to try and deal virtually with a challenging case of pediatric Crohn's disease, that's one of the sections we prepared in 2020. Feel free to go through it and see, some of the aspects we commented on today will definitely be required to go through this case. It's actually a very interesting case. And I would really like to thank you for your attention. I hope I've managed to somehow make a very complex topic as clear as possible.